Oh God. Okay. I'll try not to make this edit too much for you, Sean.
Appreciate you.
I'd say you're on a time crunch, but you've been doing it on Sunday anyway, so it's not like it's that big a
It's
deal.
on me. It's on me.
Oh God. All right, here we go. All right, guys, welcome to the R2 podcast. I am your host, Alex Coleman, here with fellow host Sean Roberts and special guest star tonight, Dr. Corey Bailey. Tonight, we are going to take you through some case studies. So Sean and I are going to present each on a case that we've seen in clinic. And Corey's going to kind of be our moderator and get us to ask some intriguing questions and spur conversation. So without further ado, Sean, why don't you get going on the first case here?
All right. So my case is going to be a little bit different than Alex's, which we thought was beneficial to see kind of the different sides of what clinical practice might look like. Soon to be Dr. Coleman is in a different setting than I am currently. My clinical setting right now is called the IHC, or the Integrated Health Center rotation that Logan does. And what that is a couple sites that Logan has teamed up with to allow chiropractors to work on patients that typically live in a low socioeconomic status. They can come to these buildings such as Affinia and CareSTL that have multiple different types of providers within them. So that can include their PCP, pharmacy, dentist, orthopedic, chiro, all the different options. So anybody that comes to see us in that clinical setting is typically referred to us for some kind of pain associated with usually musculoskeletal diagnoses. So the case that I've been seeing recently, I'll caveat that I didn't do the exam on this one, but I've seen her the last two of her 3 appointments, and I got filled in on what the exam looked like. So this lady is 46 years old. She is a native Spanish speaker, which is something that we get very commonly within the Integrated Health Centers rotations is non-native, or non-English speakers. They'll usually come in with their own interpreter, or the site will provide one, or we have access to an online interpretation service that we can use. So that's been an interesting challenge. But with this lady, she speaks very little English, and understands it at a minor level. But her primary complaint is just chronic Achilles tendinopathy. This is on only one side. I believe it's her left side. And she's been having this for years, to the point that she is now has a lot of difficulty with any kind of gait walking stuff. Her job, I believe she works at a restaurant. And with that restaurant, she's moving for hours during the shift. We have given her some exercises and stuff to do that we'll talk about. But for the most part, she tries to do them throughout the shift and just, it's not improving at all. This is 3 visits now of high rep, high dosage of isometrics and calf raises and all that stuff, just to the best of our knowledge, load the tendon. And by loading the tendon, you're hopefully building new tendon around it, especially since tendons tend to not have good blood flow. My understanding is the best way to treat them is just increase load to then build new tissue to stabilize around. However, over the last 3 visits, there's been no change in pain or function. In an original conversation with one of the chiropractors on staff, there was a potential option, and I'll pick Corey's brain on this as well, to bring her into an option for a corticosteroid injection into the Achilles. However, the doc that is on staff that would be doing that procedure is unwilling to do it. They had a diagnostic ultrasound of her Achilles and noticed that there were some small tears within the tendon, not a full rupture, probably like a grade 2. And the doc is a little concerned about putting an injection in and potentially rupturing the tendon, or the tendon failing due to the increased kind of volume of fluid that's put into the tendon. In talking to the chiropractors that are that I'm under at the IHC rotation, they're not too sure about what the research looks like on that. It seems like it might be a little bit of old news in terms of how likely that is to actually occur. And especially since she's not some kind of elite athlete that's going to be putting a lot of load through her tendon, it might be beneficial. However, we're kind of at an impasse where if that doc's unwilling to do it, it's not really an option. So all we have right now is exercise and load, but it's been making no change. However, tendons are long-term gain or game. There's a language barrier as well. And the last appointment that we had 2 days ago, she broke down like in tears fully because she just was unable to do anything. Isometric loading of the tendon, no change, walking still very uncomfortable. She asked about any kind of medication stuff she could take. She has a history of fatty liver disease. So she's concerned about ibuprofen, NSAIDs, stuff like that. She's tried things like biofreeze and stuff in the past with no help. So with that long history being said, I'll open up to Corey to see like what kind of thoughts he has or questions he might want to know.
Yeah. So first of all, the language barrier is a big factor in this case. So I had, I'll just go on a small tangent. I had a patient who I was treating who is from Mexico, speaks primarily Spanish, speaks okay English, wanted me to treat her mother. So her mother came in from Mexico, didn't speak a lick. And the communication of the language was also difficult, even in that scenario, because her English was very broken. So my biggest question mark is like, are the diagnostics accurate? And in your situation, you didn't really do that part of it. But anytime I have a situation where I'm on that third, fourth, fifth visit with no change, I'm thinking I made a mistake on the diagnostics of it. And that warrants a re-exam. I think Bo says that you should have like a 99% confidence interval, like visit 2 and 3, that you're heading in the right direction. Like you're pretty confident on what the diagnosis is. And I think this is an important point for students and new docs, is that the assessment in any scenario is like the most important piece. Because you could do a stellar treatment for whatever you think is going on, but if you don't do a thorough assessment, you're just like, you're missing the boat.
Yeah.
And so, not your fault. It's just there's a lot of factors at play here that will limit, how much you actually know is going on. And then for, I'll just kind of talk on the corticosteroid shot to the tendon. Now I believe, and don't quote me if this is wrong, but for the literature, I believe it's contraindicated, that there isn't, it's not better than other treatments. And I know that some orthopedic offices will do like a nitric oxide patch that sometimes will cause a headache for individuals. All the other palliative things, that's kind of out of our scope anyway.
Mhm.
And if this is, a chronic tendinopathy, then load from our perspective is kind of the way to go.
Mhm.
So I'll ask a question now. Even so, say you have the diagnosis right, but there's no change in what she's been dealing with in terms of discomfort and whatever and function. What would be your next step for the next visit that you see if you were in charge of the visit?
Right. Yeah. I mean, I don't know if I mentioned this originally. There's a lot of us students that work in the IHC, so there's no guarantee that you'll see the same patient every time. So that's why I didn't do the initial exam, but I've seen her the last 2 times. But yeah, from what I heard and what I've seen, there's definitely tender palpation over the Achilles. Calf raise loading the tendon is uncomfortable, doesn't really get better with time in terms of like holding that load, which tendons sometimes do, right? The more you load them, the more they kind of calm down. But yeah, in terms of like her next case, I've been talking to Dr. Lewis, who's my clinician, and it's a tough scenario because the question becomes, how chronic is it? And if it is very chronic and it just needs load, and that's the best thing we know, how much of the pain and discomfort and the frustration do we fight through before we determine that it just can't be load, right? If we think a tendon's going to take up to a year, months to hell, a couple years, at worst, then this could be the long game of just loading over and over and over. So, in my opinion, my thought would be to continue through through the pain essentially for at least a couple months. She's has like 8 visits scheduled out, and if within 2 months we've seen 0% change, then we have to start reconsidering what other options there are. Because, in my opinion, tendons are typically respond to some load, and hers are not. But I don't know if we don't have the option for an injection or some kind of steroid pack to get this to calm down, then I'm not really sure what the next choice would be.
Yeah, and your hands are kind of tied behind your back, right? Because of the setting that you're in,
Right.
the logistics of it. But to me, so if I saw this person in the clinic, even though my setting's a little bit different, I'm reassessing hands
Mhm.
down. I want to see if this, will change with repeated movements or a peripheral neurodynamic exam, with the intent in mind to desensitize it as much as possible.
Yep.
And so I ran into this actually on Wednesday, where I was working with a younger individual who had some hip pain. And from my exam, I was doing all of the right things in terms of loading, like making change to functional audits, whatever. And everything caused discomfort. And the one thing that I missed, and I had to kind of pause, take a breath, recalibrate, and reassess, was I never thought to desensitize the area first, because we want to get into the treatment, the fun stuff, right? The load, working on capacity, working on patient movement goals. But if we don't desensitize and those tissues are just irritated, you could be doing the right load for the right diagnosis, but it's just not in a place where it could handle it. And so you're right, yeah, like long time under tension for tendons is the way to go. Actually, painful eccentrics is probably better than isometrics. But isometrics don't have that, sliding between the tissues that causes inflammation. So maybe that would be a better start to send her home with. Who knows? It just comes back to, again, like, how well can you communicate with the patient? And then are your diagnostics accurate? Because that's going to be able to make sure that you're heading in the right direction without saying, let's continue with the same treatment and see, right? It kind of gives you direction.
Yeah. Yeah, I think the opportunity to reassess would be huge. I think, like like you said, the setting that I'm in right now kind of prevents that to some extent. Not fully, but it seems like this is kind of the path that with imaging through the ultrasound and IHC does a really good job of like ruling out big red flags because they see a lot of them. For example, they recently just think they diagnosed someone with Charcot-Marie tooth, or at least found something like that, so something very rare. But with that being said, that doesn't mean that this patient is going to respond tendon-wise to the way that everyone does, especially with, we know, like cultural differences and language differences. The understanding of pain and the pain experience can be very different. For example, one guy came in one time and he spoke Pashto, which is essentially like a branch off of Persian, some like Middle Eastern dialect, but the difference in like how he could explain what he was feeling to me and what I interpreted that to mean, and then what I asked him and how he interpreted that, probably lost a lot in the shuffle. So obviously this is, for this patient that we're talking about tonight, this is very very uncomfortable for her. She's unable to do a lot of things throughout her day, but it makes it very difficult that we have to then explain the pain experience and try to get her what we think is best for her without something getting lost in translation.
Yeah, it's really hard in this scenario, and Kyle Utley would be so mad at me if I didn't capitalize on this point, that the pain science side of things in this scenario, especially with people who aren't native to America, is super important for and even more important for those that don't really have the resources that you and I have for healthcare. And so I would be willing to bet that that is a big factor in this case as well. And it's evident because she did break down the last visit because she's frustrated, right? And the lovely lady that I was referring to before that didn't speak English did the same thing, like broke down because she was so frustrated that, you know, her low back hurt constantly and nobody could help her. And so, and it makes it really hard because you gotta like Google translate some words to be like, no dolor, like, you know, to try to communicate and like show that you care, because you, when you're in those interactions, you're kind of talking to the translator, but you should be actually looking at the patient because they can sense that. Right? Even though it makes it awkward and like they don't understand a word you're saying, like just giving them as much of that experience as possible may go a long way, even if like you don't implement treatment that actually helps, right?
Yeah,
because it is an experience. It's a really good point.
Yeah, so I think she'll be in next week. She's doing, they scheduled her out for essentially 8 weeks because based on the situation that she's in, the conditions that she has, that to make sure that things are hopefully progressing in the right direction. I think they wanted to make sure that she was getting in pretty consistently, which is not something that the IHC typically does. But one thing that I've kind of found with her is, I think you're right with the translator thing, is she does probably feel a disconnect in the like healthcare experience, which I think is true of anybody that I've spoken to that doesn't speak English. And this won't just happen in this setting. Like these, no matter where you're working, these people that don't speak English are all over the country. So there's a good chance that you'll run into them at some point. And I think it's a great challenge to have because it really challenges the way that you talk to patients and explain things to them in a way that can, one, be easily translated, and two, be hopefully well understood. But she is probably coming from a background in which her experience with healthcare is lackluster in a way. Yeah, it's not great because we as English speaking white men that live in the US like can get access to more or less whatever we want. And there's no barrier there. And if at the very basic level of like your hierarchy of needs, language and like socialization is very important. So her lack of trust potentially, or lack of feeling heard in a healthcare setting is probably also playing into this as well, leading to the chronification of her condition, because she is probably at the point that she feels like she can't get anything that she wants done because she can't either communicate it properly or have it communicated clearly enough to her. So that's my thought. I don't know, Alex, if you have any run-ins with situations such as these or any comment.
Yeah, I mean, I haven't yet here. I do remember working with a patient at Back Pain Center who he spoke some English, but it was very, very little. And he did not have a translator with him. So that was interesting, but it was not like in this case where it had become a chronic thing and you could tell that there were other issues involved. And something that came to mind when you were sharing it, that as it seems to me, it has grown more of like, you think that this is less of it's actually her Achilles, like the damage of her Achilles causing so much of the pain, but maybe how it's been amplified by all of the other circumstances. I was thinking that the ultrasound probably just further complicated things because it showed her that there's a tear, which depending on the exam that you didn't do, we don't know if that's actually the pain generator or not.
Yeah.
Like it could totally be, what I feel like Brinker used to say all the time, like if you imaged my Achilles, you imaged his Achilles, you image any runner who comes into his office, they probably have tears in their Achilles.
Right. Yeah.
Yeah. So I don't know if her seeing that and then it getting somehow miscommunicated to her as well, because that would have been translated, right?
And then
Yeah.
been denied a treatment that could have potentially helped, right?
Yep.
She has no idea what's going on. That's a really good point.
Right. Yeah.
Yeah,
tough.
I mean, she got told by one of the other chiropractors that they were looking into an option for an injection that might relieve pain. So now the option's on the table. So I've seen her twice, and both times she re-asked, like, is that still an option? Is that still an option? Because now it's almost like the holy grail of, if I get that, I'm out of pain. And like, obviously pain is dominating her life. So it's just like, it's that thing that probably, again, because in this case, it has nothing to do with her background or her language or something, but it's more another sense, at least probably in her eyes, that she is this close to reaching something that would help her and can't get. So again, this goes back to the population that we see, the access to care that they have significantly different than a lot of the populations that many of us wind up working with, which is kind of why I chose the rotation. But a lot of the stuff that we do, the cool DNS and all that stuff, doesn't really work in this population, right? We do a lot of resistance band deadlifts and banded pull aparts, because for most of them, we just need to get you moving, and the actual intricacies and nuances of tissue loading isn't quite as relevant as the pain experience and desensitization and, moving away from fear avoidant activities.
Yeah. We need Sean Roberts on that second exam.
Yeah, get me in there. Put me in, coach.
That's a really good point at the end. Like, just getting them moving is going to make a big difference for most of that population that comes in. And then you get a case that's like, that needs specific treatment, like loading.
Yep. Yeah.
If that is the right diagnosis, which is kind of ironic in that scenario, but.
Yep. But yeah, that's mine. So I'll probably see you again this coming week, and then we'll go from there. But yeah, when I talked to Dr. Lewis last time, it was basically, I told her, I was like, she's at her wit's end. Like, she doesn't want to do the rehab. She just wants to feel better. So I think that's kind of a weird thing that I've run into with rehab over the past few months, is just at what point is too much for the patient that day. And that's really hard to determine. Like, you got to push them to be better, but you don't want to lose them in terms of like their buy-in to what's going on. It's kind of a hard line to draw. Alex, what you got? Let's hear it.
All right. All right. So my case tonight is on a 21-year-old female Division III collegiate swimmer. She's a sprinter. She sprints the 50-meter freestyle. She's had 2-year history of right anterior shoulder pain, which has gotten progressively worse over the last few seasons. And she notes sometimes that shoulder pain kind of radiates into her pec, and she may or may not sometimes get tingling into her right hand. It mainly her pain occurs while swimming, and it usually doesn't start right away. It's like after she starts swimming, her warm up, which, done some swimming in my day whenever I was hurt running, and I was like, okay, she's probably swimming a lot. So I asked her how long her warm up was. It's like 20 minutes of swimming. So she's swimming anywhere from 5,000 to 7,000 meters every day. Well, 6 days a week, probably. So, a lot of repetition, right? And then outside of swimming, sometimes she'll get pain with an overhead lift or bench press, like if they're doing stuff in the gym. Tylenol has helped some in the past, but nothing substantial or long lasting. And the main thing is she's kind of frustrated with the athletic training staff at her school, because she just feels like she's kind of getting pushed around and a lot of passive care that nothing has really done anything to it. And they just, hey, just stretch more. So, which for most swimmers, she's a pretty mobile person. So not what she needed. And then no previous history of trauma, surgeries, or other current medications. On initial exam, so on a top tier SFMA, the outstanding things that weren't functional, non-painful, you have right upper extremity pattern 2 was functional but painful. And then single leg stance was dysfunctional, non-painful bilaterally. Actually, I might need a correction, because I think at this point I was still getting upper extremity pattern 1 and 2 mixed up. So 2 is overhead, correct? Yeah, I always got it backwards. So it is 1. So right upper extremity pattern 1, functional, painful. just reproduces that anterior shoulder pain. So then range of motion, hips within normal limits, no pain. Shoulders also has tons of range of motion. The only thing that was painful was on abduction. So she told me when she's swimming, she's mainly doing freestyle. The pain is usually when she starts to exit the water, right? And then if she's doing backstroke, it's kind of when she's going through the pool and she's about to come out of the water. So you imagine coming out of backstroke like that, we get into orthos. Jurgensen was positive. Andrews supine slap, Hawkins Kennedy, Apley scratch, empty can. So a lot of your shoulder orthos were positive, which I know that we all know is they can be hit or miss, but no cervical orthos were positive. Neuro was also unremarkable, all within normal limits. Palpation, restrictions, CT extension, upper T-spine extension, and then like tenderness over the biceps tendon. So at this point, I had a lot of pain audits, didn't really have much to go with on a functional audit other than the simple scapulothoracic stability. Like I know she's a hypermobile person and is using that a lot, so she probably lacks the stability to control it. And the theme of this case study is not to make me look good, because the first 3 visits were not great as far as like outcome goes. So I tried to rule everything out to start with. I mean, we did retractions, cervical retractions, no change. We did upper extremity like nerve flossing, no change. Put her into some DNS positions, 3-month prone, side lying, no change. We did some single arm farmer's carries and some dead hangs, no change. So I said, all right, I'm going to send her home with one thing that's like just an isometric position that's not going to hurt it. So we just did 3-month prone, and I was like, all right, I'm gonna have to talk to the docs here and figure out what we're gonna do next. So next visit, no change in symptoms. She says the 3-month prone seemed to actually aggravate her shoulder, which thought was interesting. So we did some further testing, did like quadruped rock tests, and there wasn't really any scapular winging. There was minimal movement of her scapula. She's going through the motion. Still palpatory tenderness over that biceps tendon, but also supraspinatus, and then teres major minor that had some referral kind of down into the backside of her arm. And again, no intervention that I did changed any of it really, other than the trigger point a little bit, right? I think all we did that day was like first position. And I talked about potentially needling that next visit. I was running short on time, and I'll be honest, like with the shirt she had on, I didn't feel comfortable like moving that around and needling it, being the only person that could be in the room. So I just waited till next time when I knew like Sloan would be there or somebody else would be there. So, and then we also had the discussion of this is likely coming as a result of something she's doing swimming, right? Like that's the main thing that's causing it. It's it's not really bugging her outside of that, but it's gotten mad enough that it kind of hurts outside of swimming, just doing things. So visit 3, still no improvement in her shoulder. We dry needle it, and it improves obviously the trigger point. I didn't change anything to the exercise. I think this is when she had, the next visit, she has a meet coming up. So this is the visit prior to the meet. After doing the needling, she says she's been able to swim for the last 2 days. She had been swimming, just not using her arms, like she was going on a kickboard, right? And just using her legs. But she was able to swim easy the last 2 days, and her pain wasn't bad, right? She had a little bit after the warm-up. So we were like, okay, a little progress. And I had talked to one of the other docs in here, Daniel, prior to the visit, and he goes, had you ruled out like a supraclavicular nerve, cutaneous entrapment kind of thing, because she had the radiating from the pec, right? I said, no, I didn't. So we did some cupping over that supraclavicular nerve distribution, which was palliative, and it did change some of her audits. which our main audits we just used were abduction, that right upper extremity pattern 1, and then I think Hawkins Kennedy or empty can, one of the two. Then that visit we did some DNS. We just did like a 4.5 month prone position. Again, I didn't really change her exercises, but I did tell her if she wants to, she didn't really have cups, but she said I could go to the trainer, they can cup over that area that you did if you want. It's like, yeah, you can do that. That's fine with me. So she comes back in after competing this weekend. She did shorter events on 2 different days. So she had actually she had a day in between. So she went like Friday, Sunday. Said she had no pain in her shoulder while she was competing, but she did on the warm-ups and the cool downs. So, part of it could have been, hey, I'm just out there letting adrenaline go and competing, not really thinking about my shoulder. It's also only for 25 seconds. So her warm-ups and the cool downs would have been much longer than 25 seconds. Things said, I feel like the needling and the cuppings helped, just not quite there where I'd hoped, right? At this point, we did a lot of the same stuff, and I told her, I said, hey, can you get, sorry, this was prior, for the meet, I said, hey, can you get a video of yourself swimming from the side and from the front so that we can kind of talk about it here in office? It's like, I've never analyzed anybody swimming. And we actually reached out to one of Bo's good friends, Dr. Clay Gasparovich. Sorry if I mispronounced your name, but he practiced out in South Carolina and was a former Olympic trials swimmer. So we sent the video to him, and he kind of gave us some things to think about, which was really cool. He mentioned the distance per stroke, or like stroke count, is actually a thing to consider when you're treating a female swimmer as opposed to a male, because inherently females take more strokes per 50 meters than guys will, just because they have, shorter reach, right? So if a guy is reaching, 11 strokes per 50, she's probably going to be anywhere between 14 and 17, which over the course of your practice is going to multiply the load by like a quarter. So you're going to have a quarter more reps each practice. So not that that's causing her problem, but it's putting more stress on her shoulder just inherently if it doesn't have great stability. And then the biggest finding he saw in the analysis was we were looking head on as she's swimming towards the camera, and underwater, you kind of want to see as the hand enters the water and it goes from overhead down, you kind of want to be reaching towards your pocket, right? And in a type of S type fashion. So you're kind of drawing an S with it exiting the water by your back pocket. So that way you stay streamlined and there's no extra drag. Well, on the left arm, it does just that. On the right arm, as she enters the water and starts to pull, you see her hand ulnar deviate, and then it goes out wide. So she basically has a big abduction in her upper extremity with this ulnar deviation that she then has to pull back in to exit by her pocket, which is literally the audit that she has that's painful when she reaches behind her back and so she's just putting a lot of stress on that shoulder every stroke that she's not doing on the other side. Which he said, if you look at any Olympic swimmer, they're not going to do that because it's just not efficient. So whether that's happening because of pain or she did that before, we don't know. But it's a thing to address, which came down to the discussion that I had to have with her of like, this is more between you and your coach, that like, I can't really change that for you as far as when you're in the water and you're at practice. And he probably knows a lot more about how to cue that up because he's probably seen it in swimmers before, even at the Division III level, right? So we talked about that. She decided to compete in the next meet, which was like a week later. She did 3 events back to back to back. It really flared up her shoulder. And she ended up having to scratch her events the next day. So that the last time that I met with her was when I kind of talked to her about having, bringing the video to her coach, chatting with them about that, and then going from there as far as how to work on that at practice. Because whatever we were doing in the office wasn't necessarily changing how she was doing it while she's swimming. And similar to what I've seen in the clinic here with runners and with myself, it's once you've ruled out, it's not something from the spine or a peripheral nerve entrapment, or you've ruled out the actual issue of the joint itself, and the structures around that, and you find that it's the activity you're doing, then you have to actually work on that activity, which can be frustrating because she's been swimming probably for 15 years. So who knows how long she's ingrained that pattern, but that's kind of where we left it at. I was like, I'd love to be able to help you in the future. Like, I wish I could do more in this circumstance. And that was my capacity at the point. Maybe there's something else I could have done. But from talking with the docs here, we were like, okay, it's kind of up to you and your coach now to work on that stuff. So do you guys have anything to add or question me about? Feel free to turn the grill on. I'm ready.
I think you'll be surprised at my response. I think one thing that we should do more, and this is for new docs, people that have been in the game for a while, even students, is to separate ourselves from the outcome, because it's never so clear cut like when you're seeing people in person, and we're not going to help everybody. So I think that should give you some confidence. Like, everything that you were doing assessment wise and treatment wise had some intention to help her, right? And if you show that you care in that respect, you could literally work with somebody for a year, not help them one bit functionally or with what they're feeling. But if you show that you actually care and that you're trying, I feel like a lot of times that helps, or that goes farther than actually helping them with their issue. Especially like the quick ones. Like, I just improved this person's range of motion like this, and they're like, oh wow, like mind blown, and then I never see them again. Like, it's the people that I don't help that I talk to more frequently that are more appreciative working with me, right? So we need to separate ourselves from the outcome so that we can just continue to make clinical decisions when they're in the office and we have that time with them. So you should pat yourself on the back for giving it as much as you could, as much as you did.
There's plenty of moments, man, where there was one visit that her mom came to the visit, and I was like, oh man, she brought her mom. She's like, he's not getting me any better. I'm going to intimidate him with my mom being there. Her brother's actually finishing up chiropractic school too, at Life, and seems to be like kind of on the same track as we all are with as far as how we approach treatment. And I was like, man, and she goes, yeah, he wants to chat with you about all of it. And I was like, man, the pressure's on, and I feel like I'm just not, I'm not performing, but
huge confidence shot, right?
What?
It's a huge confidence shot when that happens, right? Like, it sucks.
Yeah. And I mean, I feel like it was the reason that I wanted to bring this case, because I was chatting with Bo about what, maybe a good case to bring up. Obviously I didn't bring it because of the outcome. He said, I thought it would be cool to kind of highlight how we had to work between, like seeing that you should reach out to your peers and people who are knowledgeable in other areas of study and perform, like athletic performance. Like, I would not have recognized all that stuff with her arm that Clay pointed out, right? Like, it was glaringly obvious to him because he's seen that so many times. And it's probably a big part of it. So I think that's a really cool opportunity that we all have, that all the friends you guys have made at school and other schools, like, that they're good at this one thing, and you have a case that's tough, like, reach out to them, send them a message, call them, do whatever. I'm sure they'd be more than willing to help, right?
Yeah, clinically, I think that's super important. And like, so I work with a ton of female power lifters. I didn't know I have coached Olympic lifts before, but the sport's a little bit different than just understanding the basics. Like, you swam before, but you're not a competitive swimmer.
Right.
And so we can use our patients to learn. And I have had a lot of scenarios. Actually, recently I've had a lacrosse player, a stud in the area, had some low back pain, and I'm like, show me your swing, show me a video, like go through the motions here. Like, I want to know what you actually need to do with your sport and when you feel discomfort so that I can start breaking this down. And with that, it's so important, even if you're not going to intervene on like capacity, like actually performance training, we should understand mechanically what's going on and how to assess it and how to break it down, because that allows you the opportunity to not only learn more about different things, like different sports or different activities, but also communicate with others in that same activity and other professionals in that same activity. And so from a business perspective, that helps. From a management perspective, that helps the next time you see that, because um, it can get a little intimidating when you see somebody that does something that you don't do. Like, you are super, if that was a runner, I bet you'd be all over it, right? You would have way more confidence, you know? And so you're already kind of put at a disadvantage because you don't know like the ins and outs, like the nitty gritty, like the nuances of the sport. But as a clinician, that as providers in a profession that we're always supposed to be learning, those are like super cool interactions, right? Like, we can learn so much from those.
Mhm. Yeah. Sean, what you got?
I think it's interesting because I also think in terms of dealing with athletes, runners, for example, or really any sport, that when pain doesn't come on till activity begins. In this situation, you were able to actually find pain through orthos and stuff, but I know with runners or soccer players we've dealt with, like, pain doesn't come on until they're a decent way into their activity. That's almost the opposite conversation of what you had going on. Is what do you do in a situation where not only does their pain only like kind of show up during their activity, but what about if you can't find it at all in the office? That's why we have functional audits, right? That's why we have different assessments and different tests to do, to hopefully kind of weed that out. And like Corey's talking about, understanding the biomechanics of, they can tell you I have pain when I do this, or this is a video of what it looks like. That's always very important. But also trying to help someone without being able to get a quick audit on some things like pain can be very difficult, because whether we like it, I mean, we can be as nerdy as we want about function. People come in because they're like, I hurt, make me not hurt. And you can nerd out all day about, oh, but look at that five degrees more of internal rotation. They're like, sweet, my shoulder still hurts. So I think it's like kind of an interesting conversation, especially with athletes and endurance athletes. Swimmers can, if they're going like long distance stuff, that getting into the conversation of like, what does this look like at ground zero? Like, when you're doing it, sometimes that's where you'll find things creep up. So I guess I'd have a question for Corey. Like, where have you found that, like, where's the line that you draw of like kind of where Alex did, where this isn't my playing field anymore? And I can kind of hope you work through maybe some of these limitations and stuff, decreasing pain, throwing needling in, adjusting, whatever you want. But the where you're actually going to get the biggest effect is with working with your coach. Like, where does that decision kind of lie? Is it in your confidence of that sport, or how's that work?
Yeah, it's a good question. It's always case dependent with anything, right? Which is kind of a crappy answer. But in scenarios where it is difficult to elicit the same pain, um, and I don't have clear functional audits to work on and actually communicate, whether or not they're getting better with whatever activity causes discomfort, then I'm actually trying to find the closest thing to elicit that response, and I'll make them do it. Like, I had a 7-year-old lady with Achilles and heel pain do like single leg hops until it hurt, because she said it hurt after doing a treadmill for 15 minutes. I'm like, okay, like, what's the easiest thing I could do in the clinic right now that is the most similar to the activity you're telling me causes discomfort? And I think that's kind of the best way to go about it, especially when you don't have like, when you can't create a narrative in your head, which is already dangerous in itself. to understanding why they have discomfort with that activity at a certain time. And so an example of that would be a runner has, ankle pain at mile 5. What are you going to do? Watch them like run 5 miles? Like maybe their heel doesn't move well on that side. Okay, cool. I'm going to work on that, and then I'm going to communicate with them. Hey, like, how did it feel this time? If it moved great and they had all the range of motion in the world, and like I did a FMS on them and they cleared everything, I'm like, okay, like we really got to look into this. This is a situation where I essentially have to treat you like an elite athlete, even if you're not, right? And so I think it's always case dependent, but like just if you don't have clear functional audits and you can make those connections, you have to find a way to be able to elicit it, or you have to have other professionals that work with them to communicate with, to see if there's something missing, if that makes sense.
Yeah, because I guess I've just thought of like a golf swing, for example. Let's say everything moves well, but either they were coached poorly or they were not coached at all, or their brain just uses that motor pattern in a weird way. That's something that kind of has to be coached or has to be addressed at the level of the sport, because everything might move well, but when they try to put the whole pattern together, that's when it starts to fail. Like Alex, the
Or
swimmer, she probably moves great everywhere to some extent, but the problem is when she actually puts it all together, then things start breaking down.
yeah, and that's a good point. And I think of so a sprint in swimming, gait, a golf swing. I always just use the general term as gait, and I'll just put the sport in front of it, like golf gait, running gait, squat gait, because if you think about it, that is essentially a global movement pattern, right? There's a lot of moving parts to be able to perform that activity. And so our goal or from a treatment perspective is not to change or coach the motor pattern that is dysfunctional, right? It's to break it down and work on the area that is actually a potential limiting factor in that movement pattern. And then you'll find that that movement pattern actually changes when you find the key link. And so I can change gait, but I'm not trying to change gait while they're doing gait, right? I can change a golf swing, but I'm not trying to say, hey, move your right elbow closer to your hip as you swing. That's not my place. Same thing with the swimmer. The coach could have a really good opportunity to make change and help them feel better, right? That female case that you had, by telling them, hey, move your right arm in this way. But for me, I'm trying to think to myself, is she just doing that because she can't coordinate it and she's not coached well? Or is there actually something limiting her from doing it in the way that's more favorable? And that's like the constant challenge that you have to keep in the back of your head. Like that question should always be lingering when you're working with them.
Yeah. Well, if anybody has anything else, this is now the time to speak. Guess we're not really doing a rapid fire. Like
I'll give Corey one chance to send some drop some knowledge in at the end of this podcast.
Yeah.
So taking
I just had a baby, right? I'm kind of tired. No, I'm just kidding.
you get 5 seconds. Seeing what you've learned coming out of try 8, 9, 10, when you start treating patients, at least at Logan, to where you're at now, what's been the thing, like how has your mindset shifted and what are you looking at differently?
Well, coming out of school, I thought I knew it all. Seriously. Like, I'm like, yeah, I'm way ahead of my class in terms of classifying low back pain. Like, I'm ready to take on the world. And then you get out in real practice, like real life, and you just get hit left and right with just things that are humbling you, right? And then you have a couple cases that you do well with, and then you have a lot that you're like, man, I have no idea what the heck I'm doing. And so my mindset is like, go into every interaction. My mindset now is go into every interaction with an open mind, and try not to put myself in a box, thinking that I know what's going on when I haven't even seen them yet. And the biggest like example I can give is somebody comes in with low back pain provoked with bending and twisting, like classic, right? And morning hurts more, sitting down for long periods of time than getting up. The car is miserable. Walking is better. Like you're already thinking in your head, this person is flexion tolerant. I'm gonna do repeated movements in the opposite direction. And lo and behold, you assess them and they have all the range of motion and extension that they could have, and it doesn't make any change on their problem, right? And so we could have all of the answers, I guess, but you're going to be in for a rude awakening if that's how you're going in every situation, right? And so that's been a huge learning curve for me because of how much extra work we put in the R2P community. Like you guys work really hard to learn more. It's still a rough world out there when you're seeing real life patients and they're paying you.
Right. Dude,
So,
I should have just been a rack and crack 'em doc. It'd be so much easier.
heck, man. I mean, I would be bored, but at least the paycheck's right there. And
Bored and rich.
yeah,
Maybe disliked more.
Yeah, I'd only do it for 3 years and then I'd quit. Cool. Well, this is awesome.
I do want to say, like you two, especially going through these cases, it's so cool to see how far you come from like when we first met in club to now, because you guys are absolutely crushing. You're not even graduated yet, and you're working through these cases like better than all of your mentors did back in the day. And so you're going to come out like ready to go, ready to take on the world. Not to say you're going to get everything right, but you're going to do everything with intention. I think that matters more. And because of that, you're going to help a lot of people. So I'm proud of you guys. You're close to my heart because you came from Logan and I knew you before, but you guys are doing really good work.
Appreciate it.
Appreciate
I'll try not to cry.
Yeah. Oh man. All right, guys. Well, if for the viewers listeners viewing, if you enjoyed the case study type of format here, let us know somehow. Comment on our posts, send us a message on Instagram, whatever you want to do, send up a smoke signal. We kind of want to try some new things out. If you like doing this, then we'll do more of it. But I enjoyed it for sure. So appreciate Corey for offering his insights and showing you too. So, all right, guys, thank you for listening, and we will catch you in the next one.
See you.
All right. Stop.
Kill that recording.